our webinar series at the CXR supported incubator for AI and digital healthcare. My name is Jeff Hogg. I'm a clinician scientist based between University Hospitals Birmingham NHS Foundation Trust and the University of Birmingham. And the NIHR supported incubator is a cross-sector community aiming to collectively advance regulatory science and innovation in AI and digital healthcare, for those of you that are joining us for the first time. And this demand-led webinar series is a key part of that, as it gives us a chance to invite experts on to share their work and insights from key areas, and creates an opportunity for us as a community to dig into these exciting topics and bounce around ideas and questions. So the format of today's session and other sessions hold that in mind. And soon we'll be able to enjoy the main part of it, which is a presentation from a speaker. So we'll be in listening mode for that part, but the Q&A is a really key part of it. So we've got the button at the bottom of the screen, and I'd really encourage you to type away any thoughts you have as we go. But we'll save that for the end, where I'll chair a sort of Q&A and discussion session, inviting you to speak to your points. If Zoom allows, I'll try and unmute you, but if not, then I'll be able to read them out, so don't worry. We may not be able to get to all of your questions today, but don't be disheartened if that's the case. It's still really helpful to have them come in to help us think about what kind of topics and speakers we can invite for future seminars to make the series the best as it can be. Another key piece of housekeeping is it will be recording today's session, and you'll be able to re-watch that with links from our website, and also recommend it to any colleagues if they weren't able to join us today. So moving on to the focus for today, one of the key value propositions of clinical AI in healthcare is to rebalance demand and capacity across NHS services. And it's a really real need for the NHS, that rebalancing of demand and capacity, which is a big part of why AI was mentioned more than 100 times in the recent 10-year plan. And AI analysis of chest X-rays is a really important example of the potential for this value proposition. Because chest X-rays are done at enormously high volume across the NHS, and they have the ability to identify time-sensitive and serious diagnoses like lung cancer, so it's really impactful. It's also seen significant investment from industry in developing tools, so quite a lot of mature products on market, but also from UK government with the AI Diagnostic Fund in 2024 committing £21 million towards implementation and evaluation of tools like this. So with all that in mind, it's a real pleasure to be able to invite Dr. Rhidian Bramley to speak to us today, who's first-hand experience of the process of implementing these tools. Rhidian's a consultant radiologist at the Christie NHS Foundation Trust. He's the clinical AI lead for the Greater Manchester Alliance, and he leads work on AI deployment and evaluation, as well as having developed EPR and other software used in the NHS. So if I can invite you on, Rhidian, to share screen, I'll hand over to you, and thanks for joining us.
Thank you, Jeff. Afternoon, everybody. Thank you for inviting me to speak today. Can you see my slides okay?
That's come up really nicely. Thanks very much.
Brilliant, thank you. So, as Jeff said, the title of my talk today might suggest I'm here to discuss chest X-ray AI, and I am, but that's not really the main point. What I really want to share is how we can use data science to make a compelling evidence-based business case for why clinical AI should now be used routinely across the NHS, and perhaps more provocatively, how this same evidence helps us understand why AI should be used autonomously for reporting some cases. Now, it's a bold claim, but by the end of this talk, to convince you that's not only possible, but necessary if we're serious about tackling the challenges we face in diagnostic imaging today. So I'm a consultant radiologist with an interest in digital and data science, and I'm a member of the Royal College of Radiologists AI Committee. The Royal College, as you may know, is part of the regulatory system that Alistair Denniston talked about in his talk in a previous webinar. We look at standards and guidance on the clinical use of AI, But we're not actually a regulator as such because we don't have an enforcing role. But we are very positive about taking this forward, and we really see the potential for AI to revolutionize, particularly around patient care, but really we're concerned also around productivity and helping manage this rising demand. We also recognize the importance of oversight. I like this word. Expert oversight is essential to ensure this is safe and effective. So I'll cover some of this today and the regulatory aspects for this call. Now, there is a school of thought, and I sometimes feel like this, that radiologists promoting AI is a bit like turkeys voting for Christmas. And I get that, and I do feel that myself on times. But the reality is demand is increasing rapidly, not just in the UK. I've seen the same talks from across America as well doing this, about 5 to 10% per year. And that's more activity than we can manage. So the amount of outsourcing done out of normal hours has been increasing. It's now at 325 million, which is nearly a third of all our reporting activity is done not in core hours. And the real concern about that is despite all of that, we are still failing our patients. So this press release from the college last year, nearly 1 million patients waited more than a month for their scan results. Now, that is not good enough, is it? And we need to find some ways of addressing this to ensure that we're providing proper patient care. So the college has been really promoting this, and it's great to see now nearly 70% of departments are using clinical AI. This is in the survey that all clinical directors of radiology around the country fill in, and that's increasing. But what's of concern is that those that are using it, most of them say it's making no difference, no benefit to workload, and most of the rest are actually saying it's making it worse. So that's a real problem. Another problem is this. So the college organized a workshop and they invited NHS leaders, regulators, and also suppliers to this. And they interviewed the suppliers before they came to say, what do you see are the main barriers to implementing AI in the NHS? And the one that came out first, and it might surprise you coming from suppliers, is the lack of evidence that this works in clinical practice. Now, these are all regulatory approved. They're MHRA UK C marked, usually class 2B if they're used for clinical decision support. But that's just the starting point. They then need to be used in the NHS to generate this evidence. Now, as you're aware, NICE have evaluated a lot of these, and not one single product in radiology yet have they said represents value for money for the NHS. But the problem with this is that without that evidence, you can't get sustainable funding to be able to do it. And you need funding to be able to deploy it to actually generate the evidence. You've got a vicious circle there, which is a real problem we need to overcome. If you do get funding, then there are other challenges to face, some of them regulatory here and also around IT, but particularly around workforce and leadership. And it's kind of ironic, isn't it, that we're promoting IT to help us with workforce, but workforce itself is a big barrier to implementing it. And the evidence we've got from the surveys is it's not actually helping, it's making it worse. It's also a really difficult market. So we've had suppliers drop out. We've had Behold AI, for example, they went into administration. We've had Karen Mia, who were bought out for a fraction of the investment put into them. And we've had Blackford, one of the platforms now, withdrawing from the market. So it's a really difficult time for this. And you might have heard this expression before about the third AI winter. Some people have been talking about this. Now, personally, I don't think this is right because everyone's very excited about foundational models and what they can bring. But certainly in this narrow AI that we're doing now for clinical practice, it is a really difficult time. And if we look at the Gartner hype cycle around this, I think we are really down towards that trough of disillusionment in terms of getting these products clinically validated and the evidence available. So that's our starting point. Hopefully I've got you all in that trough of disillusionment. That was my purpose. But what I'm going to try and do for the rest of the talk is get us up this slope of enlightenment to this plateau of productivity so we all know what actually it can achieve and why we should be using it. So to start that journey, what I'm going to do is get us out of this negativity. So I've just got this slide because this is Dovedale in the Peak District, and this is a lovely place to walk. I go here with family and friends, and the kids love going across these stepping stones. And it occurred to me that this is a much better representation of what regulation is, what we want to do is get to that other bank of the river, which looks lovely. Okay, and what we need is stepping stones. And this evidence and the regulatory things we talk about are actually there to help us. They are stepping stones to try and get us to that other side of the river without getting our feet wet. And what we really want is nice stepping stones like this, nice and flat that we can walk across, that we can not only do it once, that we can do it again. But then other people can follow us. That's what we want. So it's not just us. So that's what we're working towards. In practice, when we first deploy AI, it's new to everyone, and the river looks a bit like this. You're going to get your feet getting wet going across this. As an AI lead, I often try to look and try and see, how am I going to solve this problem? How am I going to get across? But it's no point me just getting across the other side. What I need to do is make these stones better each time so that I can get across them better next time with the team that we're working with, but also other people can use them. So that's what we really are. I think we're all park keepers trying to make these stepping stones better. Now, I'll just use that analogy throughout because I think that's much more positive, and it's nice to think about dovetail. So if we think about the National AI Diagnostic Fund that Jeff mentioned, so this is fantastic, £21 million for these 66 trusts to do this. Now, Harris Sherb in his previous webinar said that a problem with this is that they haven't invested enough expertise to help the trusts, and he's got a really good point there. But I would also say that you really need to have a go at this. There's no point sitting at the bank looking across that river. You've really got to dip your toe in the water, get your feet wet to do this. You can't just buy in experts all the time. You need to build your own expertise. And the only way you can do that is by doing these projects. Now, I'm a realist. I know a lot of these projects are not going to get all the way across the other side. They're not going to generate all the evidence they need to sustain this. Okay, we didn't first time either. But the point is, we only need a few of us to get across. If some of us get across and then can show the others how to do it and create those stepping stones, that's where we need to be. And I think doing it at volume like this is really helpful. And doing it for chest x-rays, the commonest imaging test that there is, and for lung cancer, the commonest cancer, and also one of the most biologically aggressive diseases, is a really good use case about how we can potentially do this. So I'll just talk a little about the deployment. Now, there was a great webinar that hopefully some of you have seen that was done by the Reset team. So that was Angus Ramsey, Rachel Lawrence, and Kevin Hubert. And if you watch that, if you can, if you've not seen it, because it's on YouTube. And if you're watching YouTube now, click subscribe to get more wonderful AI webinars. I've always wanted to say that. But if you watch that, you'll notice they give you loads of useful stepping stones about how to do these projects, and that's by talking to all the sites. Now, I'm not going to talk much about that, but one key stepping stone, and Harris also said in his presentation, is having a platform. And I do feel that we're cheating here because we've got a platform and not everybody else has. Now, sometimes people ask, how do you get a platform through this? And the way we did it is we put it as part of our PACS procurement. So when we decided that we needed to re-procure, we decided this is not a replacement PACS. We're not buying PACS for today. We're buying a PACS for the next 10 years. And we know what's coming. It's AI. And what we want to do is be able to deploy these different AIs. We want to be able to swap them out. We want to have them integrated, and we also want to be able to evaluate them, which is key. So we've just put that as an output-based specification. We didn't say we wanted a platform, but we put it at about 15% of our scoring. That mechanism ended up with us having a platform and a really good position to be in. So when we deployed AI across the whole of Manchester, that was done within a few weeks. Technically enabled, a big stepping stone for IT, because none of the trust IT departments had to do anything apart from sign off the IG. And the IG was also a lot easier because it's a single template setup that we use. So that's a really useful lesson learned. Shadow mode is another bit I just want to mention. So you'll be aware of this. This is where you run AI in the background before you start. It's a really useful period to identify risks, get your training done, but it's also from an evidence-based perspective. It's like a trial. It's your baseline. It's what you compare against afterwards. It's your control group. And I'll show you that throughout the presentation. So the actual evaluation stage for the actual AI Diagnostic Fund is based on a baseline data collection go live, and then 6, 12, 24, 36 month returns. Now, at the moment, we've only got a few trusts that have submitted the 6 months. We're way too early to do this evaluation formally. But the reality is that the contract ends for us in June 26. And if we want to continue, we need to have our business case there now to be able to get it through Commissioner Intentions. So we've been working hard to actually generate the evidence through continuous post-market surveillance and monitoring. So what does that look like? Now, with a platform, you do get some useful information. So you can get the information from your radiology information system, PACS, and your AI into a data warehouse to be able to analyze and look at that. And that's really useful. But what we really want for this, and it's like a phase 3 clinical trial, is you need to know the patient outcomes. So the approach that we've taken is actually using the ICS approach. This is the data saving lives strategy. If you think of the Ben Goldacre review. So we're taking that information and putting it into a Greater Manchester diagnostic imaging data set and putting it into an advanced data science platform. This is a secure data environment that we have at ICS level. But we can also combine that with all our local data. This is from all the Somerset registries and EPRs, and then the national cancer and rapid cancer data sets that we're feeding in to this same secure data environment. Now, I don't expect everybody else to do that, but if you think about a phase 3 clinical trial, you don't need every trust to do this. You just need some of them to actually to generate the evidence you need to get through. So again, I feel like we're cheating because we have got this in place and we work very hard to do this in terms of contracting and IG, etc. Now, what this gives us is the ability, so we're doing 1 million chest x-rays, and I can track each of those chest x-rays so I know what the chest x-ray shows, what the AI findings are, the coded findings on the radiology report, all subsequent imaging investigations to see where they are in the pathway and resource, whether they go onto a cancer pathway and what the outcome is. Now, that's really powerful information to use. And I'll show you how we're using that. The first thing, though, to maybe talk about is risk, because we're rolling out chest x-ray AI to everyone. Okay, we've put the AI findings in PACS. It's every single adult chest x-ray, every single referral source, and all the clinicians can view it. Now, a lot of people don't do that. Most of them are very constrained rollouts. And I can understand why. Because when you first introduce AI, you've no idea about this. You don't know, and it all seems a bit of a big risk because you've got some decision support there that could cause a real problem. Because if AI is wrong and the clinicians don't know how to use it and the patient comes to harm, then you've got a real problem. And one way of mitigating that is to restrict where you roll it out to. And what often you do is roll it out just to radiologists, because radiologists are going to be less affected by automation bias. So that's the logic. However, we've rolled it out everywhere, and we've done nearly 750,000 chest x-rays, and we've been all over this looking for risk. And I can tell you how many times this has happened that we've had a patient come to our harm as a result of this, and it's actually 0. Now, just on likelihood alone, okay, now partly down to the mitigations we're in place, this has got to be low risk. Now, you don't know that when you start, and that's really helpful. That's a stepping stone for people. It is low risk. But there's another way that patients come to harm, and that's when AI is right. And what often happens, and I see this with safety cases, is that people don't look at this because they say, well, this isn't the risk of the AI, it's just the risk of the people. But when you do your DCBO 160s and you're looking at it, you're supposed to be looking at the system you implement it into, not the actual product that you're doing. And this is really interesting. So if you look, for example, Mike Jones down at Royal Surrey, when he did this, he started off very simple audit, looked at all the incidents related to chest x-ray reporting and thought, well, we've got AI now. Wonder what difference that would have made. The AI picked up 90% of those avoidable incidents, avoidable harm. I'm going to show you loads of examples where this happens. And the main reason that we get this is because we haven't turned on the AI. If you've got it in the background, you can see this and you think, my gosh, this patient has come to harm and we could have prevented it. But actually, even when you turn it on, it happens. Now, regrettably, in our area, we've actually had a patient death. And when you do the incident investigation, the AI was there and the clinician could have looked at it and it could have avoided that potential. So this is actually really high risk, and it completely trumps the automation bias. So you've got to be really careful about that when you think about it. But we do need to mitigate both of these. So how do we do that in practice? So like all IT systems, you can do it through the system where you can, and also through training. Now, I think a real innovation that only a few AI providers I've looked at do is to tell you the confidence the AI has. Now, as doctors, we're used to dealing with whole loads of different information coming to us. Now we look at all that. Some of them, sometimes it's contradictory. We put different weights on it because we've got our own neural network called our brain that we've trained up throughout medicine to be able to work this out. The problem is when we come to AI, we've no idea how much weight to put on it. And we could underuse it, we could overuse it. It's a real problem. So this confidence bar really helps because AI never gives you, well, some suppliers supply yes or no, whether it's present, but actually it's just a threshold. And if you look at the AI confidence bar, if it's close to the threshold here and with this error bars going across it, then you can tell users, it's only just over the threshold, 50-50 where it might be right or not. Have a look at the AI and you make up your decision. The more it is to the right, the more likely the AI is, but it's never going to be 100% perfect. It's going to get things wrong. It's your responsibility. So how we use that in actual practice is we also tell people to look at the X-ray first and then look at the AI. And if you see something on the X-ray, never let the AI overrule you if it says it's normal. That's another important task. But if it does spot something, what we do is we look at the X-ray in more detail, that particular area. We don't actually look at the AI, that just indicates where to look. We actually look at the underlying X-ray there and say, can we see that nodule that they're talking about in that region? Okay, and then make a decision. Because what we have is actually more information. We have our own knowledge and we have the prior radiographs to look at. And if it was there, there's nothing on the prior radiograph and it's not changed, then that's a lot more reassuring. So that's what we do. In this case, the radiologist said, I think it's okay. Okay, that's a call. And send them away with safety netting. 3 months later, they come back coughing up blood. There's a tumor there. It's done. So why did the radiologist overrule the AI there? Well, they didn't. We just hadn't given them the AI. So we ran this. This is in shadow mode. We did the AI. They didn't have access to that. This was preventable harm. So that's the sort of thing that we do. So I'm now going to go on to the evidence, okay, using it. So when NICE do their early value assessment, they don't just say it doesn't work. Now, NICE have actually said the chest X-ray AI, and I skipped over that slide, but they've actually said you must not use it in clinical practice at the moment. If you are using it, you must only do it using a proper evidence-based framework. And if you want to use, if you are going to use it at all, because it has got regulatory approval, then you must use research, NIHR or innovation funds or industry funding. So you shouldn't use core NHS. So that's quite a strong statement. But they also then provided the stepping stones. They say when you do that evidence and use their evidence standard framework, this is what you need to collect. These are the stepping stones. The first one is how accurate is the AI with a clinician. Now, you can phrase that a lot better because the AI never makes the decision. It's always the human. So actually, we're not interested in what the AI thinks. We're only interested in what the human thinks. Does the human accuracy get better with AI? Okay. First question is that important? Well, it is, because we miss 1 in 5 lung cancers on chest X-rays. That's a huge number. This is the Healthcare Safety Investigation Branch report, and they actually advise GPs on the back of this to say if you've got a normal chest X-ray and you're still concerned about the patient, they've still got symptoms, refer them in on a cancer pathway. It does make you wonder what's the point of having a chest X-ray in the first place, but missing 1 in 5 is quite a large number. It's an imperfect test. They also recommended that we look at AI to see if it can help. So can it help? Well, the scientific way to do it would be to do a study, controlled study, such as this one, looking at some of the national lung cancer screening data, number of cancers, number not. You show it to staff, different staff members with just a chest X-ray, see what they think. Bit of a washout period, show them the same chest X-ray again with the AI decision support. Do they change? And these studies tend to show the same thing. Radiologists don't get any better or minimal improvement. Non-radiologists who are not trained to look at chest X-rays, so clinicians, trainees, big improvement. So what does this tell us about where we should deploy AI? Not rocket science. People are going to benefit most, the trainees. What do we do when we roll out AI and we're worried about mitigation of risk? We just roll it out in radiology. It doesn't make sense, does it? So that's partly why we roll it out everywhere. That's the evidence. But what about real world? Okay, so what we're looking at is human performance. Remember, the college have come up with an audit to look at human performance. This has been around 20 years. Very simple. Identify a whole lot of people with a condition, in this case, lung cancer, then go back and look to see who've had the test, which is chest X-ray, and did you detect it on the test? We did that. We did nearly 4,500 lung cancers, but just over 1,600 had had a GP chest referral in the prior 6 months. We looked at all those reports and we picked up 80% It's as if we'd read the studies. So we missed a load, or did we miss them? Because if you look at them, even with an expert thoracic radiologist and knowing where the cancer is, you can't actually see it. That's a limitation of the test in about 2/3 of those. But we did miss about 6 to 7%. Okay, so these were preventable. So all you do is run over AI over those, and it picked up over a third, which if you calculate it out, because it's the number of additional cancers you can pick up compared to how many you normally pick up, is an enhanced detection rate of 3%. That's the actual metric that is intended for you for this type of evaluation. Now, that is actually the maximum you could pick up if the human went along with the decision support in each case. So it's likely to be less. But you've also got to think about automation bias. So you can run AI over all the ones that you detected, and AI doesn't pick them up. As you can see from these two figures, AI isn't quite as good as the human, and it does miss some cancers here. So in theory, this could cancel each other out. But through your training and saying, look, if you see something, don't let AI overrule you. This should be minimized. And if you train them the right way, this should be maximized. So you should get an enhanced detection in real world. And if it's 1%, that would be for us 12 extra cancers diagnosed a year in Manchester. That is about 1 in 10,000 radiographs that it would make a difference on. Based on the cost about AI, that's about £10,000 for each cancer. If we say an extra 6 months survival on average, and if you're looking qualies, it's about £20,000, which is round about a nice threshold, okay? But it's small. These are actually those cancers. So all of these were a preventable miss, okay, where the AI clearly flagged the cancer that was missed. So based on a large data. So we've written this up, it's been published now. Can we see it in the real world? Well, the columns here are the number of chest x-rays we do each month. We do about 40,000, and the orange line is the number of cancers. If anything, it's gone slightly down, the number of detection, but it's not statistically significant. In fact, we're not going to see this in a prospective study. If you look at these numbers and say, what do we need in terms of randomized control trial to pick up this? We're talking over 20 million chest x-rays. It's not going to happen. And at the same time as this, we're rolling out national lung cancer screening, which is taking a whole load of these cancers out of the system already. So we've got a changing population. So we're not going to see it, but you can generate the evidence in the way I've just described. Well, I said it's people outside radiology that benefit the most. So, for example, if I look at this, which is detection of pneumothorax, this is a real problem because if you miss a pneumothorax, the patient can die. If you overcall it and put a chest drain in someone, you can kill them. So it's something you might want to audit when you start. This is a great example from our first AI project that we did. It called a pneumothorax here. Now we train doctors that skin folds can mimic pneumothoraces. This is a clear skin fold. I'm sure AI could be trained to pick these up with a bit more training, but this is something that it does. Now, the doctor put this in as a near miss because he said, well, it's overcalled here. But it did actually flag something up here, which he thought was a near miss as well. But then he looked down and said, actually, you flagged a very subtle rib fracture, so perhaps that is real. So he did the sensible thing and asked the radiologist, who did a sensible thing, got a CT scan. So that was a false positive. As predicted, this was a true positive. The patient was managed appropriately. So AI did help here, despite overcalling. Okay, so we've had a look at this in A&E, quick audit. If you look at just over 100 AI pneumothoraces, we find that actually 65 were true positive, according to an expert radiologist. Now, the actual ground tooth is probably a CT scan because radiologists can miss these easily as well. So that's a positive predictive value of about just over 60%. First question is, my gosh, only 6 out of 10 times they're saying a pneumothorax is right. So are we actually patients coming to harm as a result of overcalling? None of these came to harm. We've done loads of stuff, so nobody's ever come to harm about any of what we've done. But then again, how many of these are the A&E doctors picking up? Are these true positives? And they're missing loads. They were missing loads on this particular audit. Now, this was done by radiology. So we flagged this, but there was a big enhanced detection rate with AI. We flagged this to A&E, and they said, well, actually, we may need to read between the lines here because we don't always document it. We might be able to work out from other things. So they redid it. This is a much bigger number, similar positive predictive value. Now, much smaller number missed here, and the detection rate goes down. So this is actually getting the A&E doctors to do it. But what is surprising, they're still missing loads. So we clearly need to give more training to A&E doctors. If you're interested, about over 3/4 of our chest x-rays reported by radiographers, reporting radiographers in Manchester, and their accuracy without AI was over 98%. So very good. So probably not going to get any value for radiographers because they're really, really good. But there we are. This is a good example. And we can do it for a whole load of conditions, vertebral fractures, NG tubes, etc. So that's enhanced detection, which you can make a business case on alone, but you need more usually. This is one of them, time to report a chest x-ray. Okay, now, is this important? Well, yes. In Manchester, we had over 17,000 unreported chest x-rays when we started, and over 15% were taking more than 2 weeks to report. So what's the idea? Well, AI reads the chest x-ray straight away, puts a flag on it, pushes it to the front of the reporting queue. We diagnose lung cancer quicker. Couldn't be easier. So we did it the same way. First time we did this, like most trusts do. We get some radiologist clinicians to decide which AI to prioritize. They say what they are. Then you turn on the AI and you realize actually that's about 30–40% of your chest x-rays. They say we can't do that because we've got a massive backlog. We need to concentrate on those. So some negotiation, you take things out and you get about 20% or less. And then we say, yep, go ahead and do it. So we did that and we were really just, let's have a look and we can roll it out, show it works. And they came back and they say it doesn't work. They're not being reported any faster. It's taking us longer. It's less efficient. Oh my God. Oh dear. So what was going wrong? So this is when I realized data science needs to come into it. And actually why they were failing here was actually really obvious. It's not data science, it's not rocket science even. So what they'd done is they'd carved out 20% of their capacity to report these abnormal ones. And then everyone else said, go do what you normally do. So we had 20% of the reporters reporting 20% of the x-rays. The other 80% were reporting the 80%. They go at the same rate, don't they? So it doesn't get any better. And what's more, then you ask the 20% reporting the abnormal ones how it's going, and they say, well, it's taking us longer because they're reporting all the normal ones. So it's amazing what you can do if you don't think about it. So I had to do a bit more to convince them. So we built a simulation model of patients coming into a hospital and going home, and what happens in terms of waiting list methodology for what happens and the amount that you prioritize and percent. So you can work out different models without doing it on patients. And what you do find is if you increase the amount of people that are reporting them, yes, you clear them all and they're all done very quickly, but the backlog goes up, which is what you'd expect as well, which they didn't want either. So it's a real problem because which of these 124 findings on our chest x-ray solution analyses do we prioritize? Because all of these, actually, many of these could be due to cancer and all of these are important. So it's quite a difficult problem. So just to recap, what we want to do is push these to the front of the queue. Every reaction has an equal opposite reaction. So these actually get pushed back. Okay, so we want to make sure all the cancers are here, because if there's any cancers here or significant pathology, we've actually made them worse. So we do need to think about this properly. So what we did is we took those, we ran them over all of the cancers. I told you we've got a whole load of cancers that we know we can actually identify in a chest x-ray. And then we also run the AI over a whole load of referrals where only 1% have got cancer. So that gives us a whole load of data where we can work out what AI findings are statistically associated with cancer as opposed to normal. You can look at prevalence ratios. A lot of these appear in combination, so then do a multi-regression analysis. And that actually works out that we have to prioritize quite a lot of findings, and including other findings that might not be related to cancer, which we got through clinical review. That's about 22% of GP referrals, nearly 42% of chest x-rays overall. Now, still a lot of people didn't believe this. They say, no, that can't be right. We're worried about this. So you can build further simulation models. You can see what happens when you prioritize. And what happens is that some will go forward, some will go back in a queue. And it really depends on the prevalence of the cancer in the group. And you can do this and they can say, well, actually, we think we prefer this model. And if you run that like Matthew Broderick in War Games, you can see that doing what they wanted to do, which was a small amount, some of them were pushed to the front, but actually most cancers got worse. If you do what the data science tells you, actually most of them are getting better and a few were getting worse. So we managed to convince most people through this route. The other lot said they were doing anyway, providing I stopped showing them these models because I was driving them mad. Either way, it was a win. So that's what we did. But I cheated as well here on this because I didn't like these being pushed back at all. So I used the simulation models to work out what would it take to act them, make them no worse off, which reduces your average turnaround. So it's a bit of extra capacity for a short period of time. Build that all into the model. So we need to report chest x-rays in 24 hours. That's the target, the national target. How are we doing? So this is in shadow mode. The AI is not turned on. We're running it in the background. We can see which ones we're going to prioritize, which is around about 30% here. These are the blue ones. The gray ones are not. So we do about 8,000 chest x-rays a week in Manchester. And we can see that actually we're only turning around about 20% in the target time frame. And in fact, we're turning around the normals faster than the abnormals. That's our current best practice before with the AI. It didn't work last time. I've trained everybody up. Turn it on. Is it going to work? Yes. So we're now over 90% of cancers being reported within 24 hours and nearly all by within 2 days. So it does work. And actually, these are no worse off. So data science does work. Yes, you can turn them around. So again, another argument in favor of the case. The problem is if I take both of these to the finance directors or anything, they will just throw me out and say, well, where is the money coming from, Rhidian? Where is it? And I can talk about qualities and they say, well, I don't see that. Where is the money? Because we've got to pay for this. If you can identify the money, we do it. So NICE said you need to look at resource use. So does it increase our productivity or numbers referred for CT scan? Do we save money? So we looked at 370,000. I thought it might get worse actually, because why would it get better? It's an extra thing to look at. No change. About 120 seconds, median and mean to report a chest x-ray across all our trusts. So no difference. That's great. No worse, but it's not a business case, is it? So we also looked at CT scans. So the metric the AIDF is using is CTs within 28 days of the chest x-ray. That's a reasonable amount of time because some people have got backlog to say if there was anything on the chest x-ray, we would expect that. So we looked at this and we started off, we're doing 40,000 chest x-rays a month. And the orange line is the percent that of those chest x-rays that go to a CT within 28 days. It's quite a high percent, is it? Started off at 9%, ended on 10%. So we're doing more CT scans. That's the wrong way. It's costing us more money for a small increase in number of cancers. It's not going to get a business case on that. So is that the end of it? Well, if you've got the data, you can look at the data in different ways. So there's no step up here, is there, when we go clinically live, which is a bit of a clue. So if we look back 10 years, we can see it's been up and down, dropped a bit for the pandemic, the number of x-rays, which are the blue columns, the percentage has been going up. It was actually only less than 6% back in 2017, and it's gone up more rapidly. So actually, it's plateauing after we've implemented AI, which might be a good thing. But why is it going up? What's going on? So we code all our chest x-rays. This is really useful for valuation. The GPs love it as well because it shows them what to do. So CXR means we can't see anything concerning, but safety net because 1 in 5 cancers are missed on a chest x-ray. So they get the guidance. So chest x-ray 1 is infection. National guidance is follow-up chest x-ray because there may be a cancer underlying it. And then CX2 and CX3, we do a CT scan. Okay, so we've got those. Let's have a look at these CTs done within 28 days. Well, I was surprised because the majority of them are where the chest x-ray is normal. Nothing to do with us in radiology. The rest, we've actually recommended a chest x-ray in 6 weeks. They're having CT scans. So what's going on? It's over 3/4. Only a quarter we're referring. Okay, a lot of CT scans. Okay, so we had a clue though, because that national guidance came out, hasn't it? And since that national guidance came out, the number of 2-week referrals for lung cancer has been going up and up. In fact, people have been flagging it and saying, our referrals are going up, but our cancer rates are staying the same. You know, it's not helping. So what we did is we looked at those normals, where the AI said it's normal, because obviously you get a bit of enhanced detection rate with AI, and where the human has said it's normal. And we looked at the conversion rates to cancer. And the conversion rate is very low within that first 28 days. You know, negative predictive value is incredibly high. That might not mean anything, but if I tell you that if you just went out onto the street and you grabbed people off the street and you gave them CT scans, you are far more likely to pick up a cancer than if you actually do a CT scan in this group of people. So we discussed this with all the pathway board and everything, and we changed away from the national guidance and we updated it and said, we're not going to do CT scans within 28 days unless there's some real clear symptoms like coughing up blood. Okay, so these are the changes to the guidelines that we did, and you can model out what the effect of that is because it reverses some of these 2-week rate referrals. And it works out at nearly a saving across Manchester of nearly £1 million a year. There's your business case. Okay, so what we've got through this, it's the positive predictive value, okay, of detecting things, which gives you early diagnosis and faster diagnosis. It's the negative predictive value that's doing the business case for you. Okay, It's that bit of combination. The same product can do the same things. You just use different thresholds for what you want to do. Now, this is actually all using the same threshold, but it does bring us to the final thing I just want to talk about is, can we allow the AI to report some chest x-rays? We've got a high negative predictive value. The stepping stones for this, though, look a bit like this. Okay, for a start, public attitudes. All the surveys show, this is one by the Health Foundation, human in the loop, checking everything. They're all quite happy with AI being used. As soon as you remove the human from the loop, they don't like it. They've all watched Terminator 2. They know what happens. If you, another stepping stone, who takes liability? This is the Medical Protection Society. They did a talk. Well, they said without actually redefining this, the human, the reporter, is always going to be the liability sink. And if the human reporter is going to be the liability, then we advise you to make sure that you're always reporting them. You are the human in the loop. That's exactly what they said here. The clinician must retain the final decision-making authority. So that's something to consider, who takes responsibility. Although we do have NHS indemnity, don't we? So we actually, that covers off if we do get sued. And then IRMA did their amendment, and they kept stressing the role of the human operator, and it must be overseen by human duty officers. There must be a named person. So these are all stepping stones that we need to work on, but they're not beyond us. But we know AI, the actual definition is doing tasks that we normally require. It's not really human intelligence if it's just operating there with a bit of decision support. So to really make it intelligent, it needs to do our role, and we need to think about how it can. Now, I shared this with Alistair, and he thought it was quite useful, so I'll share it with you. There are two main ways we provide oversight: the human in the loop and human on the loop. All of it at the moment is human in the loop. The human checks and reports every scan. That's entirely sensible. But there is a tipping point I've indicated here, and that tipping point occurs when the AI is better than the human. Because the AI is more accurate and the human's checking it, then we're correcting the AI and getting it wrong more often than we're not. We're actually making it worse. It does not make sense to have a human open the loop model when the AI is better than the human, okay, on average. They still may add value because the actual AI is better at the moment. So when we do this, we're asking this question: what value does the AI read add? If the AI is better than the human, and we have the AI doing the first read, as it is, we should be asking what value does the human read add? So, good thing about AI is you can define what a high confidence normal is. So you've got loads of things. You can decide what you want to prioritize, but also each of these you can set thresholds for. So you've got huge things you can change, okay? And you can offer different thresholds for different use cases. If we, just for this hypothetical thing, we say, if a chest x-ray has got none of these 124 findings at our normal operating points, we'll say that's normal, because we wouldn't comment on anything, okay? How good is it if we do that? Well, I've told you in our study, the reporters picked up 81%. At that threshold, AI is picking up over 99% of the cancers. So it's better than us. So what value is the human adding? Well, this is actually 25%. A quarter of our GP referral chest x-rays are high confidence normal by this definition. They have no AI findings. So we looked at first nearly 10,000 coming through, one of our trusts, median follow-up of 6 months. Oh dear, 4 lung cancers, 28 non-lung cancers subsequently diagnosed in this group. You might as well abandon it then. Or do you? What value did the humans add? Well, they actually agreed in 98% of them. But the others, they actually recommended 161 follow-up chest x-rays and 32 CT scans. So there were a lot of stuff done. So what value did that add? None. They didn't pick up a single cancer. Even statistically, you would think they would have picked up one, but no. The cost of that and all the additional tests ran out at £43,000 plus additional variety. That's far more than the cost of AI in picking up a cancer, doing the humans. But statistically, what happens if they did pick up one? Does that mean that we have to do it? Well, use the same principle. So if we use our big retrospective set, 260,000 x-rays, 65,000 high confidence normal, we looked at that, 13 lung cancers were missed, okay, on that high confidence threshold. The humans picked up 4. So the humans added value. Great. What value though? 4 additional cancers for 65,000 at £4 a chest x-ray is £65,000 for cancer detected. And that doesn't even take into account the massive number of extra investigations they did. It's probably closer to £80,000 for additional cancer, okay, which is around £160,000 for a quali. Doesn't even meet the threshold for AI. And you have to remember, AI missed 4, Don't get worried about that, because this pays for the AI, and you pick up additional 38 for the enhanced detection rate. So logically, it makes sense to do it. And I think we can arrange these things in discussion with the CQC AI leads, and they say, well, actually, with the evidence presented like that, the current legislation, providing you have a person that says, we've evaluated this, we're monitoring it, we've got post-market surveillance in, we're showing that it's continuing, we're maintaining the accuracy of AI at that threshold, they said that would be fine in the current legislation. They would say that is okay from an IRMA's perspective. Okay, I'm sure public can be convinced. Public are convinced about autonomous AI or autonomous systems. I mean, we don't open train doors when they're moving, or plane doors, do we? Because it's not safe. We do allow responsibilities. So providing the profession backs it up, we can do it. And then ultimately the NHS takes liability. So these should be able to be lined up. It shouldn't be too hard. And I think we just need to push this through, get that evidence published, more people doing it. And there we are. So thank you very much. That was a big rush through, but I hope that's food for thought about how we can generate the case, and really why we should all be doing chest X-ray AI now, because it's quite a compelling case.
Thanks so much, Rhidian. That was really, really interesting. Great to get down into the weeds of, at a really applied level, thinking about business cases and where the value add is and all that kind of thing. I'm going to leap straight into the questions which are coming in. And I'm going to try and unmute Jack McLeod, if that's okay. Can you have a go at speaking, Jack? I think I've unmuted you, and it'd be great if you could speak to your question.
Can you hear me now?
Yep.
I kind of got two questions, actually. The first question was in regards to what your thoughts about the impact of AI on developing doctors was, in regards to becoming that expert to oversee the AI system, if the AI system is making decisions to a higher level than them. In 5 to 10 years' time, will we have sort of an intellectual deficit as a consequence of that? And also, do you know of any AI models which describe how they've come to their findings to facilitate that learning, or not?
Yeah, so that's a really good question. It's something that's debated quite a lot. Obviously, there's pros and cons, because AI can really help with education in some cases, but if you don't have the right blend of education and you're just reliant on it, then it's not going to help you. Now, what we're talking about here is taking out a whole load of normals. Now, people say, well, I need a whole load of normals to get my benchmark. Well, no, you don't. You need actually the reference population you're looking at to get your benchmark. So if you take out a load of normals, you adjust your benchmark about what things are. And actually, you get more pathology, so you get better training. Okay, I work at a cancer center. I hardly see any normals. That doesn't make me a worse radiologist. You just adapt to what the new situation is. I've had trainees say, actually, it's really helpful having the AI there, because it's that second pair of eyes. It can be difficult to ask somebody to see it, and it points out things that I miss. Okay, and when I see it, I think, oh yeah, actually it's right. So it can really help with training as well. Talking about narrow AI models as well, if you look at foundational models, I mean, so if you look at Sal Khan and the Khan Academy, so he developed AI essentially to train underprivileged kids in maths, to show how can AI support, like personalized medicine, personalized education. And it's a Socratic method. The AI doesn't tell you the answer. It's done in a way that brings you to where you want to be. And that's won so many awards. It's a really great educational tool. And educators are increasingly recognized that it's really valuable. Oxford have just paid for open AI edu licenses to all trainees across Oxford. So I think we are moving into the bit actually realizing it's not a threat, it's an opportunity. We do need to mitigate the risks, but I think it will help us.
Thank you.
Thanks, Jack. Thanks, Rhidian.
I don't know if there's a second question there, but
yeah, that's right.
The other point was just in regards to how you foresee the role of a diagnostic radiologist changing alongside AI, because I feel a lot of the sort of more simple reporting roles will probably be absorbed by those systems. And obviously, we've got a big deficit in the number of consultants at the moment. Do you think that deficit needs to be filled if AI will come and help the deficit? Or do you think actually we'll need a lot fewer consultants?
Well, to chest X-ray AI, it's already happened, doesn't it? Our largest trust outsources 90% of their chest X-rays for reporting, and most of those are done by radiographers. If we look at the rest of the trust, 75% are done by radiographers. We've already bought in SkillMux. we've already gone out, and the radiographers, when we surveyed them, they really like the AI. They like that extra decision support. So it evolves, doesn't it? Our profession evolves. People say we act at the scope of our game. I mean, that's a worry, because if you've got more complex cases you're doing all the time, you can get more burnout. But hopefully it will give us the right blend. I mean, all this different AI together, there's increasing evidence coming out that it can reduce a whole lot of administration burden with the foundational models. So it is going to change. We don't know fully how, but we just got to manage it appropriately and try and get it in the right way so we reduce burnout and have a nice, fulfilling life. I don't want to be sat there just clicking yes all the time, confirming an AI. But I think it'll be a long time before we do that. And it's not good use of our time if we're not adding value. So, which is why I say we need some of them done autonomously.
Thank you.
Thanks very much. And next, I'll bring in Mike Newnham, if that's okay. Mike, hopefully you're unmuted. If you could speak to your questions, that'd be great.
Yeah, can you hear me okay?
Yep.
Thanks, Rhidian. So I'm a lung cancer clinician and clinical academic, so I really enjoyed your talk. So I've got two questions. I'll take them in turn, if that's okay. So the first is just, what are the ramifications of utilising AI for chest X-ray interpretation on other parts of the 28-day faster diagnostic standard pathway? So are there unintended consequences as your denominator goes up? So does it increase things like triage demands?
I mean, the pathway is really interesting, isn't it? The actual, if you look at the faster diagnosis standards, the time between the chest X-ray and report is actually not part of it, is it? It's that day -3 to 0. So when the AIDF said we'll look at faster diagnosis, we said, well, it's probably not going to change it because it's not that part of the pathway. But we use this as an opportunity to look at everything, from the AI, because what we find is when we introduce AI, you really look at a pathway, and it's a real catalyst for change and to try and improve things. So we've looked at from chest X-ray report to CT, and what can we do about improving that? Pathways such as the chest X-ray report, when we say it needs a CT, is the IRMA referrer. We've got that through for the CT scan. Doesn't need to go back to the referrer to go, oh yes, you've said to do a CT, I need to fill in a form. It's all arranged, sorted out with the patients. That reduces steps in the flow and speeds things up. And I think, I mean, if you see this, if you've probably seen your 2-week wait referral clinics going up and up and up because of that guidance, and your conversion rates going down. If you can free up that time for you to spend it more productively with your patients by getting the right patients coming to you, then that is a bonus as well, isn't it? So, but we don't want to miss cancers because there's a huge push to do that. So we're doing further research to try and work out which ones should get a CT. How can we best predict, including the Medley study, which is being in the Northwest and various things. But there's a lot of further work going on there. I've done some really interesting, love to pick it up on actually clinical symptoms and what they are, because things like breathlessness, we say persistent breathlessness and cough. Actually, when you do the statistic analysis, they're actually protective symptoms. You've got less chance of diagnosing cancer when you've got those. It's normally something else. So we need to use the data science in our referral guidelines as well. But the GPs love this. They absolutely love it. They say it's quite, especially the CX codes, really clarified what they need to do. They hate words like atelectasis because they have no idea what it means or what to do. Clear coded guidance instructions about what you need to do, and it's gone down very well. So it's gone down well with GPs. It's gone down well with the whole pathway board redesigned all this. Clinicians love it because it's when the providers love the fact that it's actually saving money for the economy. Patients on the pathway board think it's great. Loads of unnecessary tests. They don't like all this additional anxiety. It seems a win-win. So it's fantastic. That's why I want to share this, because it seems to be such a positive, good news story.
If there's time, I've got another question. In fact, I've got a bunch of questions, but in the interest of time, I know that there's other people that want to speak. But Jeffrey, is it okay if I ask another
maybe
question?
just one more, if that's all right, Mike?
That's fine. So were there differences in the cancer detection rates between the GP chest X-rays and the ED chest X-rays? And are you deploying this for inpatient chest X-rays as well? Or is it just a selected group?
Yeah, every adult chest X-ray across Manchester, so that's 1 million over the 2 years. Yep. So when we looked at cancers, they come from GPs, similar, actually slightly more through A&E route than the GP route, and then the rest through obviously outpatients and inpatients. So they present from all areas, and that's why we said, look, your traditional ways of prioritizing, maybe report the GPs first, or there was no logic before. We had one trust which has got 2 sites, and one site said we're reporting all the GPs first because nobody else looks at those and they're likely to have the cancer. And the other site said we're reporting all the A&Es because they're sicker patients and we need to make sure they get looked after. It's mad. Logically, and this is what the data science shows, is if you report the abnormal ones first, less patient harm, faster turnaround for treatment of disease. So yes, yeah, there's quite a lot of difference in incidence between them and what percentage are normal. I think I told you, look at using that, about 20% of the GP chest X-rays were abnormal in terms of prioritization, is about 40% of A&Es. So there is a difference because they're sicker patients, aren't they?
That's great, thank you.
Thanks very much. Next, I'll bring in Alistair. Alistair Dennison, who's got a question in the chat as well. Hopefully you can talk, Alistair.
Hi, yeah, thanks, Rhidian. Brilliant, really lovely to see all that presented, and thanks for sharing that in the loop, on the loop way of describing, which I think is really helpful, particularly and for those listening as well, just as you're trying to communicate this whole area of when we're allowing AI to be used in this role. Yeah, I was just wondering whether when I see you set this out so clearly and in a way that seems intelligible to kind of the executive teams and commissioners, do you see this as the methodology and the learning you've done here as being something that you can lift and drop into other pathways as well for use of AI? Because I guess one of the concerns I have is it's hard for our decision makers to make sensible decisions in relation to AI when all the evidence they're presented with looks slightly different. Whereas if we can say present them with something that basically looks the same as what you've done here, then it's really compelling. And the answer won't always be yes, but it helps them make a better decision. So yeah, any thoughts?
Well, I think that was my intention, because we're using the same methodology, for example, for prostate MRI AI, and it's looking at enhanced detection. Okay, looking at can we improve turnaround time in the abnormal ones and the pathway, and then what's the negative predictive value? Can we avoid unnecessary prostate biopsies? And that's actually where you make the savings. You make the savings on the negative predictive value, and you make the quality improvements on the other aspects, the enhanced detection, the triage. So it is, I think, really a template we can use. I think it is worth saying as well, this is a template for the NHS. The business model is different. So if you're in America, enhanced detection, they don't get much money for doing chest X-rays. It's a loss leader. But if it increases the number of CT scans you do, then they generate revenue. So they're actually looking to do the opposite of what I'm suggesting here and actually generate more demand because that's their business case. If you look at teleradiology companies, they're more interested in peer review, making sure the quality is right because their insurance premiums are quite high. The second pair of eye and reducing those. The business case varies depending on the sector that you're in. But for the NHS, I think we need to identify savings. It's absolutely right that it's health economics, isn't it? We use our resources in the best way.
Thank you. It was brilliant.
Thanks very much. If you'll forgive me going a minute or two over time, there's a question in the chat I'd really like to speak to. It's come up as anonymous, unfortunately, but essentially asks, with the configurability that you've shown of setting what a high confidence normal is on the ground in your deployment context, what are the implications for system or national level gatekeepers like the MHRA or NICE that are trying to make assurances and judgments on whether a technology is or is not good enough to be used if we anticipate and want that degree of change and nuance at a local level?
Yeah, so I think the human on the loop is what you still have to do. All of these key things is you have to present the evidence first to get the MHRA UKC mark to say, yes, it's better than the human. Then you've got to validate it in your local data and show it. And you can decide. Now we're putting an NIHRA research grant in to look at high confidence normals to generate more information. And that involves a loop process where we iterate over actually working out what to prioritize and what thresholds to use to try and optimize it. And I think Ben Wilson asked a question on the previous call about how important is data science to this. And as Ben Goldrick and anybody else would say, it is really important. So if you're actually generating the evidence and doing the validations, having a team, as in the Goldacre review with data scientists working with clinicians and do this, absolutely essential to generate this evidence and work it out. Once you've generated the evidence, like a phase 3 trial, other people can use it. You don't need quite the same level of evidence generation and reassurance, but you do need that appropriate post-market surveillance and monitoring to make sure that it's safe. And Irma and everybody else would say, I want to make sure that's in place, because you've got AI reporting something. You need to make sure there's no drift and all these other things. So, we need to work, and Alistair will be doing it through the commission and other things to really frame this and get those stepping stones lined up so everybody's happy. But it will take some of us to do it first of all, and others to follow, I think. So,
Brilliant. Thanks so much, Rhidian. Thank you for a really insightful talk. Really appreciate that and the time this afternoon. So all that's left, really, apart from saying a big thank you, is for me to wrap up and to just give audience a bit of a heads up that next month, on Tuesday, the 11th of November, we'll be having a talk on post-market surveillance of clinical AI from Sarah Mather, who's been working on the RCR guidance on post-market surveillance too, and shared some insights into that. So look forward to next month too, and thanks again to everybody for joining us, and enjoy your evening.
thank you.